Yeah, that's great. I think it's a great conversation to be having. So I think between myself and Andy, we're just going to go over, I think, just at a very basic level, conceptualization of sort of what ECMO is, how it works, and the very sort of basics of the mental model of how we manage these patients. I will start at the beginning, but I think we'll try to answer some of these three very basic questions to begin with in my beginning introduction is sort of what is VV ECMO? What are the indications to refer someone for that as a therapy? And then what is the benefit of it in people that have severe respiratory failure? So what is it accomplishing for us? And that's a very good place to start. And I think Andy will sort of take it from there in terms of some of the management nuances that Dr. Cameron was referring to. So again, to begin very basically, VV ECMO is a form of extracorporeal life support. Obviously, there are a number of different therapies that fall into that category, whether it's sort of, VV via ECMO, there's lots of different mechanical support devices, but it's a form of extracorporeal life support. And it provides support for the lungs, but not the heart specifically. And it will replace the function of your native lungs with an external membrane lung, or a membrane oxygenator. And what this accomplishes is that venous blood that's deoxygenated comes out of the body. The oxygenator or the membrane lung will add oxygen and remove carbon dioxide, and then return that back into the patient in their venous circulation. So as just a very brief schematic that we can sort of look at, if we look down here, there's a drainage tube that is bringing some of the venous blood out of this patient in their femoral vein in this case. And there's a pump that's helping move that blood around in the circuit. And then this is the membrane lung. So there's an interface between gas and blood. So those are separated by a membrane. And this blender, which is moving air and oxygen through the membrane lung, the same way a ventilator moves air and oxygen to the patient, allows this blood gas interface to bring oxygen into the blood and carbon dioxide out. And then on the other side of the membrane lung, the goal is to have blood that has more oxygen, less carbon dioxide than when it started. And we return that back into the patient's venous circulation. So that can be done a number of different ways. It's sort of maybe less important to consider when you choose each of these different strategies, but you basically have to find a place to put a large cannula to drain venous blood into the circuit, and then a smaller cannula to put it back in the body. So that can be in both femoral veins, more commonly, why I've highlighted it in the red square here, but the femoral vein and internal jugular vein are the two most sort of common locations for people in acute respiratory failure. And we also have these double lumen cannulas where you can just have one insertion site. And if you look at a cross section of the cannula, there's sort of two working channels inside of it. And one of them can be for draining the deoxygenated blood, and one of them can be for returning the oxygenated blood just from one access site. So this is what, excuse me, the centrifugal pump looks like usually on these circuits. So there's an inlet, and then the pump sort of spins around, which is why it's called centrifugal, because it's just spinning, and then sends the blood in the outlet port, and that goes into the membrane lung. So there are multiple different companies that make multiple different membrane lungs or membrane oxygenators. This is the Quadrox, which is the one that's most commonly used here with the equipment that we have. And if you look at the setup, there's a place for blood to go in and come out, and a place for gas to go in and come out. And the interface is a lot of these small polymer tubes that are crossing over and overlapping each other to allow blood, gas, and sort of water or moisture to flow through the area, and obviously create a very large surface area of blood to gas interface to allow that gas exchange to happen. So if you like, as far as VV ECMO is concerned, this is kind of where the magic is happening in the circuit. And what that ultimately ends up looking like, as many of us have seen at the bedside, is a large cart with multiple different machines. But ultimately down here in this little sort of drum area is where the pump is. And then this diamond-shaped membrane lung is where the gas exchange is happening in the blood interface. And then that'll be sort of set up on a cart like this with some other machines to sort of monitor different metrics of blood temperature, oxygen saturation, and a sort of heater cooler exchanger at the bottom just to regulate the temperature of the blood in the circuit. We also have this cardio help circuit, which is basically the same thing as this previous one, the Rotoflow system, but it's just more compact. And as you can see, the pump and the membrane lung, membrane oxygenator are sort of connected in one unit just to make it more compact. and the console to control the speed and the other metrics and measurements that you get from the console are sort of all condensed into this one small unit that's a bit easier to travel. So again, this at the bedside would look something like this. So if that's the equipment that we work with, what are the indications for referring patients for VV ECMO? So Critical Care Services Ontario have a provincially agreed upon set of standards and a sort of guideline document to help us as well as other hospitals in the region who are considering critical inter-hospital transfer referrals to help us all be on the same page about when patients should be considered for this therapy. So this is from the CCSO document that you can find on the Critical Care Services Ontario website. And I'll show you each of these in slightly more magnification so you can see, but patients to consider are those that have acute respiratory distress syndrome or acute respiratory failure. And that can either be from hypoxia or hypercapnic respiratory failure. Status asthmaticus is sort of a less common indication, but it's still on the list. And then a group of patients that we don't necessarily see locally not having a lung transplant program, but also to help bridge patients to receive transplant lungs, or also to help patients who have received transplant lungs that have graft dysfunction recover after lung transplantation. So those are patients we're obviously not really going to see locally. I guess there would be some exceptions to that, but largely we're going to deal with the ARDS and hypercapnic respiratory failure population. Things you have to keep in mind in patients that we should not be considering it are, a lot of these things are things that would severely limit the patient's lifespan. So do you have a disseminated malignancy that's going to limit the quantity of life that you have remaining? Do you have a severe brain injury? Again, sort of your quality and quantity of life may influence the utility of using ECMO in a patient like that, and also the risk of intracranial hemorrhage from anticoagulation needs to be considered. Prolonged CPR without adequate tissue perfusion, so running an arrest with significant downtime or sort of no flow time from not starting CPR. Severe chronic organ dysfunction, and whether that's sort of end-stage lung disease, end-stage liver disease, some of these other severe end organ dysfunctions that can limit your quantity of life. Severe chronic pulmonary hypertension, and then non-recoverable comorbidities, again, sort of advanced like neuromuscular disease or terminal malignancies. So again, these all absolute contraindications are, is there sort of a non-recoverable illness or significant chronic comorbidity that's going to limit the patient's capacity to survive or limit their lifespan in general? Relative contraindications include patients who have contraindications to anticoagulation, which is not an absolute contraindication, but for a lot of people would limit their ability to be considered for ECMO. And then other things like advanced age or obesity, again, relative contraindications. And then end-stage renal disease, you really have to sort of take that into context. Is it a younger, healthy person that happens to be on dialysis, or is it an older person with multiple comorbidities and also has end-stage renal disease? So that's why some of these things at the bottom are relative contraindications. And if you look at the sort of severity of ARDS, mild, moderate, severe, the patients with severe ARDS refractory to sort of all evidence-based therapies are the ones that we should consider. So in patients that have PF ratio less than 150 with uncompensated hypercapnia and their pH is low, so respiratory acidosis on high levels of PEEP, the evidence-based therapies we should all consider for these people include prone positioning, using sort of the ARDS lung protective ventilation strategies with PEEP tables, considering paralytic as well, and the possibility of inhaled pulmonary vasodilators or recruitment maneuvers if you think it's going to be beneficial. But I think we all know that things like nitric oxide often just make the O2 better, but doesn't really help any clinical outcomes. So those can be a bit confounding sometimes. But well outlined in the document is that you should kind of exhaust the evidence-based therapies that you have to the best of your ability before you consider something that's on the edges of the maximum amount of life support that we can give people. Because often by someone starting out with severe hypercapnia or hypoxia, if we do some of these things, they will improve significantly, and obviously prone positioning likely has less risks to the patient than having them anticoagulated on ECMO for a significant amount of time. So if you look at the bottom here, if the patient's PF ratio is less than 80 for 6 hours or less than 50 for 3 hours, or if their PCO2 is greater than 60 for greater than 6 hours, and that unreadable text at the bottom basically says you should be like maximizing their minute ventilation while still failing to resolve their hypercapnia. So that's respiratory rate 35 breaths per minute, and maximizing your pressure control or tidal volume depending on your mandatory ventilation mode to keep the plateau pressure less than 32. So if you're failing to achieve any of those targets, you should consider referral for ECMO. One other thing to consider, patients should be mechanically ventilated for less than 7 days, because after they've been mechanically ventilated for more than 7 days, the burden of ventilator-induced lung injury and other things like possible ICU-acquired weakness from paralytic and steroids and some of the other things that we give may start to affect their ability to survive an ECMO run. So sort of earlier is better if it looks like the patient possibly is going to head in this direction. BMI of less than 40, which again is not an absolute contraindication, but possibly a relative contraindication. And then age from 18 to 65. And again, that's just trying to select the patients that we think are going to benefit and have capacity to recover. So if those are the patients we should consider, the next question should be, how does this help? So what is it actually accomplishing and what does it do? And the main thing that it helps us accomplish is to minimize ventilator-induced lung injury. That includes barotrauma, volume trauma, adduct trauma, myotrauma, oxygen toxicity, all of these things that are sort of associated with struggling to achieve lung protective ventilation in a patient that has ongoing hypoxia or hypercapnia at unsafe levels. So it allows you to achieve lung rest while getting gas exchange through the membrane. And essentially the way it should be thought about is it really allows you to turn the ECMO circuit on so you can really turn the ventilator off and minimize ventilator-induced lung injury in someone that you're really struggling to ventilate and failing to achieve those targets that are defined in that document. So really any problems that you have with CO2 clearance or hypoxia can then be managed with the circuit without having to adjust ventilator settings. And that is reflected if you look at our local ECMO patient management guideline document that Dr. Nagpal has put together for us. If you look at what the ventilator modes are for immediate post-cannulation care, you should be aiming essentially for pressure control of 10, plateau pressure of 25. Look at the tidal volume, it's 0 to 4 cc's per kilo. So this is sort of ultra low tidal volume lung protective ventilation. Inspiratory time less than 1, PEEP of 10 to 15, respiratory rate of 6 to 10, and FiO2 of less than 60. So the most recent patient that was transferred from CCTC, basically once he arrived, got put on a rate of 10, pressure control of 10, PEEP of 10, and FiO2 of 30%, while the circuit allowed his lungs to rest. So really backing way off on ventilation, just to try and avoid sort of adduct trauma or volley trauma or barotrauma, considering that open lung model, and then just allowing the circuit to do everything else. And you'll note, just emphasizing that avoidance of trauma, we should avoid using recruitment maneuvers, PV tools, APRV, any of those things that have a risk of causing ventilator-induced trauma to the lungs. So that, as an introduction about what is ECMO, who to consider, and what's the benefit, is a good place to start. And I think I'll hand it over to Andy just to keep going from there.
All right, thanks, John. Let me just pull up the other part of the presentation here. All right, so you guys should be seeing the second part of the presentation that says post-cannulation management now.
Looks good.
Okay. So John's really led me into the next part of this is, what do we do once we get them on pump? And where do we go from there? And again, we were asked just to give kind of a very general overview of what like the thinking is around this and what some of the goals are. So a lot of things are probably oversimplified. And I think this is actually a really complicated topic, and a lot of centers really struggle with how to operationalize this well, particularly in COVID. So I'm going to start by just giving an overview. So as John mentioned, the goals are really to stop hurting the lungs. Once you've pulled the trigger and put someone on ECMO, you might as well take advantage of it and stop damaging the lungs on the ventilator with the strategies he mentioned. And then what we're seeing in COVID and some of these other patients is they're on there for a long time. So if you're not going to use the lungs and you're going to have to be on ECMO, what other benefits can you get from it? And the thinking around here is to focus on what we know there's benefits of around sedation, liberalizing, paralytics, things like that. And that's, again, hard to operationalize, and those things are needed when they're necessary. But if they're not necessary, we know there's harm associated with them. But then that's obviously balanced against the risk with ECMO. It's not normal to take all your blood and put it through plastic tubing. And that comes with a ton of complications. And a lot of people actually die of the complications of ECMO. So that's why you'll often see some variation in practice around people trying to push to get off ECMO faster and things like that to avoid some of these complications that can arise. So when thinking about what we're trying to do, I think it's helpful to think about the potential for lung recovery. When we think about VA ECMO and stuff like that, we talk about bridge to transplant, bridge to recovery, et cetera. And I think it's the same concepts in the lungs. And I sort of imagine that there's 4 different kind of phenotypes around this. And that on one extreme, you would have no potential recovery. So the patient who's going to get a lung transplant. And historically, these have been patients who have been sicker, maybe in hospital, and because of their lung disease, they're not doing well. And putting them on ECMO allows them to rehab and get strong and better withstand having a lung transplant. So these patients are getting extubated, they're getting Avalon cannulas in, and they're getting up and walking around, and sort of analogous to like a durable LVAD and sending people home and getting them well again. So if that's one extreme, that you don't expect the lung to recover at all, and you're really taking full advantage of ECMO. The other extreme is probably the very bad pneumonia, which is a case that happened at CCTC just last week. Someone rapidly decompensated because of a Staph aureus pneumonia, and they really reached the end of what you could safely do on the ventilator. So they were put on VV ECMO and transferred to UH. And all we really did in this case was rest them for a bit and let them get over their shock. And then start to wake them up, stop paralyzing them, and see if their lungs had recovered. And their lungs started to recover. So we switched to the ventilator. We stayed like that for a day or so. Their lungs seemed to tolerate safely providing gas exchange. So we decannulated them. So that would be the other extreme, where you get this, you have a really bad problem that's treatable and it rapidly gets better. And I think in the middle of those 2 extremes is probably where a lot of the challenge comes to manage these patients. Historically, that's been ARDS for in the intensive care world, where you're not quite certain if and how quickly lungs will recover. And you're maybe sitting on ECMO for days or even a couple of weeks in extreme cases. But then came along COVID, and this is an unheard of beast. You guys have everybody's now experienced some of the challenges around these patients. There's chronic ones in each unit, and their lungs just don't recover for weeks or months. And then there's a lot of uniqueness around their sedation requirements, their work of breathing, and as well as some of the stuff that pops up. They're coagulopathic, they bleed, they clot, they get all sorts of too complicated in the chronic phase than we're used to. And I think that very unique beast that we're putting on ECMO and unique challenges. So John alluded to what we should be considering on the ventilator. So I won't belabor it too much, but the evidence really lies around this concept of low or ultra low tidal volumes, or essentially the concept of avoiding ventilator-induced lung injury. And that comes from the Eolia trial. And we know that it's safe to do that. And that's where the best evidence lies, minimizing ventilator-induced lung injury. You'll see some practice variation around that. And, it's kind of analogous to, I think when remdesivir was first on the scene, there was some excitement to use it, but we acknowledge that there's not a clear benefit. And outside of the research realm, we shouldn't necessarily be doing those things. And I think a lot of what people are trying on ECMO with the ventilator is in that realm. There's maybe some good physiologic rationale and there's maybe some centers pushing it. There's not clear evidence that these things are useful. And you'll see variations in trying high PEEP to improve compliance, allowing for spontaneous breathing, and even extubated patients. And again, there's lots of good rationale for that, but these things are still in the realm of research, and not every high volume center is doing these things. There's a push to try them, but again, the evidence is really in this idea of just letting the lungs rest, letting them recover, and waiting for the function to return. And in the case of COVID, a lot of centers are not seeing function return for 6, 8 weeks, and even months. And it's a real struggle to decide what to do. And a lot of centers that have high volumes of these, it's just accepted that you just have to wait until either you have complications that say that you can't go on, or wait until they recover if you just have single organ system dysfunction. And the lungs will tell you when they get better, because their compliance will improve and your tidal volumes will come up. So if we accept that we're going to be on, if we're essentially going to shut the lungs off and let them tell us when they're better, then what gains can we make? And it does make sense to think about sedation and paralysis, because again, we know these things have benefits in certain circumstances, and we know they're necessary to provide care in some circumstances. And we also know there's harm associated with them. ICU weakness, it keeps people in the ICU, all sorts of problems. So the general concept is ideally we minimize sedation and paralysis. Maybe getting a lot of eye rolls on that one, but I put in this statement, it's practically more challenging than that, and particularly in COVID. So we're not the only ones who are seeing that these COVID patients have huge drives to breathe and ventilator dyssynchrony, and a lot of difficulty in actually lifting sedation. There's a recent webinar from STS that had a lot of the large American centers talking, and this is the crux of where the challenge on these ECMO patients lies, is they struggle to wean sedation on them and get them up, but that is the ultimate goal, because there's so much benefit in doing that. And it's interesting that is part of the push to do early ECMO, is to actually avoid these truckloads of sedation that we get people on beforehand. Because it's definitely, that seems to be a factor, is they just get on so much sedation and analgesia that it becomes a challenge to wean it. So this is hard, but it is the goal. And then what we see as we wean sedation that you run into is flow variations in the hypoxemia that results in that. The ECMO circuit is very dependent on preload and afterload for maintaining flow. So if either of those things change, then flow through the circuit will change. And I thought it was worthwhile just to go through that in a sort of simplified schematic way. I think everybody's got different backgrounds, so this may be something that some are familiar with and some aren't, but not this part particularly. But if you look, you have venous blood that returns to the right side of the heart. It's deoxygenated. It goes to the lungs put oxygen into it, but then the left side pumps it back to the rest of the body and goes to this box of organs, which is heart surgeons, is the rest of the body. So if we consider what happens on ECMO, let's just acknowledge that your lungs don't work because Dr. Landau has put them on 10, 10, 10, and 30% FiO2. So you need some kind of oxygenator, and that's where ECMO comes in. And what we do is we divert venous flow to the oxygenator. The oxygenator oxygenates it and pumps it back to the right side of the heart, where then you get fully oxygenated blood going to the lungs that don't do anything and returning it back to the heart. So that's sort of in a very simplified way of what's going on with ECMO. I want to highlight what happens if you decrease flow. So let's say the ECMO is set to RPMs that put it at 5 liters of flow per minute, and you turn it down to 2.5. You're going to have less blood going to the oxygenator and less oxygenated blood then coming out and going to the right side of the heart. So if 2.5 are going to the oxygenator, another 2.5 are not going to go to the oxygenator. They're just going to bypass the ECMO altogether. So that blood's going to remain deoxygenated. Then you're going to get mixing in the right ventricle, and you're going to get deoxygenated blood going to the lungs and deoxygenated blood going to the left side, then back around systemically. So which is manifested as low sat. So one way that SATs can be affected is by decreasing flow through the pump. And this is assuming everything else is working correctly, right? Like the oxygenators working, the FiO2s on, all that. So the other way that can happen is, suppose you go back to this normal ECMO circuit and your cardiac output is 5 liters per minute, which is sort of a normalist cardiac output. Let's say you're septic and that doubles and it's now 10 liters per minute. You're gonna have twice as much venous return. 5 liters per minute is gonna go to the pump because that's what you crank the RPMs to. So the other 5 liters is gonna hypothetically bypass the pump and you're gonna get mixing. And then you're gonna get deoxygenated blood that goes to the lungs, back to the left side, and to the rest of the body. So what I've highlighted is when the lungs aren't doing anything, oxygenation is dependent on flow through the ECMO circuit. So if you decrease flow through the ECMO circuit or you increase native cardiac output, you will see hypoxemia. So sepsis may create hypoxemia or changing flow because you've changed preload and afterload. So that brings us to suck downs and flow variation. And again, the reason why I'm highlighting this is because this is one of the challenges we have as we wake people. As they wake up, they start to move around, they cough, and you get changes in preload, and then you get changes in flow through the ECMO circuit, and it manifests as hypoxemia. And there's not a lot immediately in your toolkit to deal with that, as the nurse at the bedside with, you know, someone who's unfamiliar with medicine as one of the residents in the middle of the night. Really, your toolkit is fluid and paralysis, which isn't necessarily the optimal answer to that. And I'll just explain why. But if you look at this picture here, it just shows a cannula in the right atrium. So if you imagine that, you know, it's basically just sitting a sack of fluid, like a milk bag or something. So on the right, you have a milk bag with a straw in it. And let's say you tried to drink that fluorescent pink milk and the straw was right near the plastic, the edge of the plastic. If you sucked really hard, you'd suck the plastic in and you wouldn't get any more tasty milk. And your natural what you would do to solve that problem is just stop sucking. But what we do to the ECMO patient is we paralyze them and put more milk into the bag, which again, that's the toolkit we have, but it's not the intuitive answer. The intuitive answer would be to temporarily stop sucking or to suck less. So that kind of brings us to how we try to manage hypoxemia in these ECMO patients as we wake them up. And one of the things you'll see that we should try to do is decrease the ECMO flows and tolerate a lower oxygen saturation. If you're sucking less, then you're going to be less prone to having suck downs, which create these catastrophic scenarios where the machine's screaming, the monitor's screaming, and it turns something that's mundane into an exciting moment. So that's one strategy. The other period is to tolerate transient periods of hypoxemia. And we know that's safe. It's uncomfortable to look at, but it's safe and it promotes avoiding dumping volume and sedatives and paralysis in to treat this problem. But then the other thing that you'll see as the lungs start to recover, maybe having a little bit more FiO2 that's still at a safe level, but will oxygenate some of that shunting blood. So just to summarize, the main sort of guiding principles in this, and it's a very complicated topic and a challenging topic around the world to deal with, but the guiding principles are avoiding ventilator-induced lung injury, trying to minimize sedation if we can, recognizing that's not always easy to do, particularly in COVID patients. And then we want to reduce the flows when the patient's more stable, so that we can avoid flow-related hypoxemia. And then the final principle is that the lungs will tell us when they're ready. So if you just left them on 10, 10, and 10, as compliance increases, you'll see tidal volumes come up, and they'll let you know that they're ready. But the problem is, as humans and physicians and healthcare teams, we're impatient, and that may be 2 months from now. And that's what the rest of the world is seeing, that some of these ECMO patients for COVID, it's taking months for their lungs to recover, but they do recover. But it's just very abnormal for us to be dealing with this type of patient on ECMO. And that's really it. We can open it up for some conversation now.
Yeah, thank you very much to Doctors Landau and Fagan, and thanks everybody for showing up again. I will stop